Opioid receptors comprise four subtypes. The MOP, mu opioid receptor, delta opioid receptor, kappa opioid receptor, and nociceptive opioid receptor. So now they are termed as MOP, DOP, KOP, and NOP. All are having selective endogenous peptides for their own and elicited by opioids. Their names have been elicited by the drugs which were found to activate them. So they are found to be present in different anatomical locations. And, they were named by the compounds which were eventually used to stimulate them. So morphine gives the name mu, ketocycloxane gives the word kappa, and it was delta was located in vas deferens, so it was called delta or D receptor. And the fourth opioid receptor included in the opioid receptor family is termed the nociceptin orphanin FQ peptide receptor. So all of them are G protein coupled receptors sharing the same similar transmembrane topology, and they have no direct link to effector proteins. So instead, they message the relays via the G protein. And opioid receptors and the non-classical NOP opioid receptors are all inhibitory G proteins. So the G proteins, there are three types: GI, GS, and GQ. So GI stands for inhibitory, GS stimulatory, and GQ is the third type. So this is the inhibitory type of G protein receptor, and their activation leads to three changes. One is closing of voltage sensitive calcium channel, stimulation of potassium efflux, causing hyperpolarization, and reduced cyclic adenosine monophosphate. So all these things are shown in this picture. Calcium is prevented from coming in. There is a negative symbol here. Potassium is excluded out, causing more negative charge inside, which is called hyperpolarization. And depression or blocking of adenyl cyclase, so reduced neurotransmitter cyclic AMP release, all these things. So if you can just remember this simple diagram, you can mention the mechanism of activation of these G protein coupled receptors, which are inhibitory. So these three mechanisms result in reduced neuronal cell excitation, reduced transmission, and also inhibit the neurotransmitter release. So this is how the neurological effects are produced. And there are endogenous and exogenous ligands which are able to stimulate these things. So the endogenous opioid peptides are four types: pro-enkephalin, pro-opiomelanocortin, pro-dynorphin, and 3-pro-NOFQ peptide. So the endogenous delta opioid receptors are activated by enkephalin and enkephalin, which are cleaved from pro-enkephalin. So there are no direct metenkephalin and enkephalin. They are produced by breaking this pro-enkephalin. For the kappa receptors, KOP receptors, there is the dynorphin A and B, which are produced from the pro-dynorphin peptide. And for the pro-opiomelanocortin produces a product called B-endorphin, which is agonist to all three, both MOP, KOP, and DOP. At all levels, the beta endorphin activates them. So the amount of this endogenous peptide presence determines the ability of a person to tolerate the pain. The classical example they used to give is a person living in the city. When he gets hurt, he will be feeling the pain too much and he will be making a lot of fuss. Whereas a farmer working in the field, even if he gets hurt, he will be able to tolerate the pain more easily than the urban people who are not used to that hard work and other things. That is probably because their endogenous peptide levels are higher. So they are able to tolerate the pain much better than the people who have lesser amount of this endogenous peptide. So the selectivity of these things are given in this chart. So this is how all these four opioid receptors are there and their sensitivity to this endogenous. And to come to know about the supraspinal analgesia of opioids, how they are activated is here there are the mu opioid receptors start analgesia supraspinally also. For that you have what is called, there are on cells and off cells present in the rostral ventral medulla. This is one mechanism I thought it will be useful for you to remember how the for practical examination more than the theory. So if the examiner asks how intrathecal morphine or epidural morphine works by supraspinal message, this is the mechanism. So there are off cells and on cells. So the MOP agonists cause analgesia supraspinally by inhibiting the on cells. That is the removal of the GABA mediated inhibition resulting from firing off the off cells and activation of descending inhibitory control analgesia. So normally the inhibitory pathways are inhibited by GABA release. So that is blocked by this on cells, and the inhibitory descending pathways are able to act on the dorsal horn cells and reduce the conduction of painful stimulus. And that is how the supraspinal analgesia happens. So this picture, if you can remember, will be easy for you. And individually, the mu opioid receptor are located throughout the central nervous system, and they are more present in the cerebral cortex and amygdala, and their highest density found in caudate abdomen, and they are present in the presynaptic area of the primary afferent nerve and within the dorsal horn also, and they inhibit the glutamate release, that is the receptor transmitter substance which is present throughout it, and hence transmission of nociceptal stimuli from C and A beta fibers are reduced. And the major side effects are respiratory depression and reduction in the sensitivity of chemoreceptors to hypercapnia. That is why even when the respiratory rate goes down, naturally you will have hypercarbia, but that hypercarbia is not able to stimulate the respiratory drive and as it normally happens. That is why the morphine respiratory depression slowly kills the patient. And the MOP also inhibits gastric tract secretion and inhibits the peristalsis, causing constipation. These are the two important side effects of the mu receptors or morphine drug. And the delta receptor, they are found mostly in the olfactory bulb and cerebral cortex, nucleus accumbens and caudate and putamen. And they are located presynaptically again, like your MOP receptors, and they inhibit the release of neurotransmitter also. And the kappa opioid receptors are, they don't cause respiratory depression, but they are responsible for the dysphoria that can happen when the opioids are taken. And the nociceptive receptor, they play a role in the development of tolerance to morphine analgesia. So this point is very important because in cancer patients, we use a lot of morphine to relieve their pain. And the mechanism why they develop tolerance is because of the activation of these MOP receptors. And this is a picture to show where all these receptors are present in the central nervous system. And this is again a picture to show the mechanism of action, the three main actions: calcium influx blocked, potassium efflux stimulated, and the cyclic AMP levels are decreased. So this is how the whole thing happens. And clinical effects mediated by opioid receptors are supraspinal analgesia, spinal analgesia, respiratory depression, and euphoria. They are present mostly with MOP. So the mu receptors are only responsible for supraspinal analgesia and spinal analgesia. And the respiratory depression is maximum with mu receptors only. So, and, so these are the points I thought will be useful to describe the opioid receptors. Okay. I think a lot of people have left because all the theory questions are a little boring topics. So You can't keep yourself attracted to these things. Unfortunately, we have to learn all these gray areas also. So can't help it too much. Shall we call it a day? Martin?
Yes, sir.
Dr. Kamakshi there?
I'm here, sir.
Yeah.
Hello, sir.
I think we have finished all the questions discussion.
Yes, sir.
Shall we close
So
down?
next week, yeah, yes, sir. Next week question, sir. Any prompt, sir? Can we
I
have
have
something on
I have
anemia,
not
sir?
thought about it. I think the way the theory discussion class goes on, I don't think people will be very much interested in that.
Yes, sir. We can have some clinical topics, sir. Anemia, pregnancy.
We'll decide about it later.
Ah, yes, sir. Okay, sir. Thank you so
Thank
much,
you.
sir. Thank you.